Hey everyone, welcome back to the channel. Today we're going to talk about a tricky concept in anaesthetics, and that's the difference between graded and Quantal response risk curves, which will allow us to talk about efficacy and potency, and I'll use opioids as an example. And then we'll talk about Rocuronium, which is a non-depolarising neuromuscular blocker commonly used in anaesthetics, as an example to try to illustrate another tricky concept that comes up, known as the ED95 and the ED50, which can mean different things depending on if you're talking about graded or Quantal dose response curves. From there, we will talk about things that change Rocuronium's potency, and an interesting fact I just learnt today about how Rocuronium's duration of action seems to also be diurnal. So let's begin with graded dose response curves. So graded dose response curves show how the response of an individual increases as the drug's dose increases. You can get a little effect to a moderate effect to a maximal effect, and it's continuous and a not all or nothing response. Now there are two ways to graph this. You can graph your y-axis as a percent response, and your x-axis can either be dose or log dose. And you can see the shapes vary, with log dose being a sigmoid shape. The important thing though is that we can see that as dose increases, the response increases in the individual person, depending on what is being measured. Examples of things that can be measured are things like increasing sedation depth, increasing blood pressure, or a reduction in muscle strength compared to the patient's baseline, or you can even measure how well an analgesic works from no pain relief to complete pain relief. Typically, of these two graphs though, we want to use the log dose response, and this is for several reasons. When we graph dose against effect on a linear scale, most of the curve is compressed at the low dose end, and the clinically useful portion sits in a very narrow window. This makes the relationship look steep and hard to interpret, so instead we use what's called a logarithm of the dose, or a log dose, and that fixes several problems. The first is this crowding that we see at the start. So it spreads out the dose range where most clinical changes occur. So many drugs act over multiple orders of magnitude in dose. For example, it can go from 0.01 milligrams to 0.1 milligrams to 1 milligram to 10 milligrams, which all cause different responses. On a linear scale, those lower doses are squashed together, and the log transforming doses spreads out these effects so the curve becomes more readable. The second is that it converts the curve into a smoother sigmoid shape. With linear dose, the dose response curve is very steep at the start, and it's unhelpful to be able to see what the differences are if you're trying to really figure out what doses are actually causing the most amount of difference. So taking the log dose gives us a low dose range with minimal effect, a mid dose range where it's steep, and this is the useful part of the curve where we're getting the most effect for the dose, and then the high dose range where it plateaus near the maximum effect. This allows us to clearly see where the effective dose 50 lies, which I'll talk about later, and the slope of the response is greatest, so we can see where this maximal effect occurs with an increasing dose. And we can see the increasing doses where there's no longer an increasing effect or a ceiling effect, also known as this EMAX, which is the maximum effect. It also makes comparing drugs to themselves and to other drugs much more easier. So on a log dose scale, small shifts in the curve left or right show potency differences and the effect of disease states on how the drugs interact, and drug interactions when there's things like antagonists, enzyme inducers, and volatiles that are present, which I'll talk about when we talk about opioids. Without log scaling, these shifts would be very subtle and almost invisible and hard to see. It also reflects biology better. Physiological responses often follow logarithmic patterns, with receptor binding and drug effect increasing rapidly after a threshold is reached. So for opioids and neuromuscular blockers, you need to reach a certain amount of receptor occupancy to be able to see a clinical effect. So a log scale aligns with this natural behaviour better than a linear one. So to keep things simple, we'll only use the log dose scale from here on, which is the one that looks like a sigmoid shaped curve. And from it, we can determine things such as the EMAX, which is the maximal possible effect, which is the height up to 100%. We can also figure out the effective concentration 50, known as the EC50, or another name for it is the effective dose 50, which is the ED50. And it depends if you're measuring a dose or a plasma concentration. So this is the dose needed to achieve 50% of the maximum effect. And we often use this when we talk about concepts such as potency. So potency and efficacy are two concepts that come up regularly when we talk about these types of graphs. Potency is your ED50. And if you have a lower ED50, meaning the curve is shifted to the left, then you have a drug that is more potent. And if you have a higher ED50, which is a curve shifted to the right, you have a drug that is less potent. Because what it's saying is that for these doses, you're achieving 50% effect. So if it's shifted to the left, you can use a lower dose to achieve 50% of the effect. Efficacy is how much it can develop a response. So a full agonist, for example, can achieve 100% efficacy because it can achieve 100% response, where a partial agonist can only achieve, say, 60 to 80% efficacy compared to the full agonist because it can't achieve that full 100% response. And that's where you can see partial and full agonists on this type of graph. So a classic way you might be asked about this is when discussing opioids. And the response would represent analgesic response on our y-axis. And if we were to graph morphine and fentanyl, which are both full agonists, you would see that fentanyl, which is more potent than morphine, sits to the left on this graph, while morphine sits to the right, meaning that you need a higher dose of morphine to achieve the same effect as fentanyl. But both can achieve 100% effect because they're both full agonists. While if we talk about something like buprenorphine, which is a partial agonist, buprenorphine is interesting because it's more potent than morphine, so it sits to the left, but it's not as potent as fentanyl, so it sits to the right of fentanyl, but its efficacy, or its EMAX, does not reach 100%, so it's a partial agonist. Then the other concept that they may throw into a question like this is how would naloxone affect your full agonist? So naloxone is a competitive antagonist, so it will shift the fentanyl and the morphine curve to the right, therefore increasing their ED50s, which decreases their potency. But because it's a competitive antagonist, meaning it shares the same receptor binding site, its effects can be overcome by increasing the dose, so the efficacy is unchanged. They both still reach 100%. But if you have something such as a non-competitive antagonist, then both the potency is decreased, so it shifts to the right, and the efficacy is also decreased because a non-competitive antagonist binds to a different receptor binding site on the same receptor, leading to negative allosteric modulation usually, which can't be overcome with increased dose of the drug. I won't go much further into this, but this is a great question that can be asked as it tests our knowledge on full and partial agonists and pharmacokinetic topics as well. If we go back to neuromuscular blocking drugs, the ED50 works for most drugs, but when it comes to things like intubating someone and paralyzing or giving someone a muscle relaxant, you want to know with certainty that the dose you're giving is going to give you a desired effect. So your question becomes more binary rather than a response, and this is where a Quantal dose response curve comes in. So we'll draw the Quantal dose response curve to the right of this graded response curve. And you can see here that a Quantal dose response curve is trying to ask a binary question, which is an all or nothing response. So instead of measuring how strong the response is on the y-axis, we're measuring whether the response occurs or not. And we're doing this across a population, not in one person. So examples of this that you might want to measure are things like sleep. So the question is the person asleep or not asleep? In seizures, you might ask, is the person having a seizure or has the seizure been aborted? And for neuromuscular blockade, the question we ask is there a 95% twitch suppression or not in the first twitch done compared to their baseline? The important details that we can get from a Quantal data is you can get an ED50 as well, which is the dose at which 50% of the population shows that binary effect. You can get an ED95, which is the dose for 95% of the population that shows that effect. And then we like to use things like toxic dose 50 or lethal dose 50, which is the percent of the population that has either an undesirable effect, such as with toxic dose 50, or LD50, which is 50% of the population where the dose is lethal to them. But the caveat here is that we don't actually know the lethal dose 50 in humans because these are from animal models and they're extrapolated, and then we make a guess as to the dose that's lethal to humans. Often we don't even know the lethal dose 50 for animal models because, again, we wouldn't ethically do that to animals. So again, these are usually just extrapolated data. We can also figure out something called the therapeutic index, which is a safety margin, which is the toxic dose 50 divided by the effective dose 50. And this range is the therapeutic index. So your toxic dose 50 might be, for example, if you're talking about opioids, when nausea develops or respiratory depression develops in someone, while your ED50 is when 50% of the population have good analgesic control or no pain. So that therapeutic index is the difference between those two doses. So just to summarize, graded dose response curves tell us how increasing doses affect response in a single individual, and the response is continuous on a spectrum. It's not just a yes or no question. While a quantal dose response curve looks at the dose response relationship across a population, and it's a binary question. So you're asking, does the patient have analgesic control or not? Or does the patient have a 95% reduction in the first twitch height or not with the neuromuscular blocking drug? So neuromuscular blocking drugs, we often would rather use the quantal dose response curves when we're talking about them. This is where ED95 and ED50 get a bit confusing with neuromuscular blocking drugs. When I give a neuromuscular blocker, what I really want to know is whether what I'm giving will reliably block enough nicotinic receptors to provide adequate intubating conditions. On our dose response curve, the number chosen was 95% reduction in the first twitch height when measuring a train of 4 in the adductor pollicis of the thumb, which is where you stimulate the ulnar nerve and measure the movement of the thumb and you compare it to the patient's baseline. So paralysis of the thumb muscle is slightly delayed after paralysis of the larynx, which is where we want to put the tube. So by the time the thumb is paralyzed, the larynx should be as well. But there's a caveat though, because it's also possible that the larynx may be beginning to recover by the time the thumb is paralyzed, but that's beyond the scope of this video and maybe for a different video. So on our graded response, a 95% reduction sits quite high here and represents the ED95 for our individual, which you'll see is around 0.3 milligrams per kilogram for Rocuronium. Then if we transfer that to our ED50 on our Quantal response, then what we're actually saying is that 50% of the population will have a 95% reduction in the first twitch height. But that means 50% of the population won't, because it's a spread of everyone on a bell curve because everyone's different. So some people won't have much reduction in their twitch height while others will. So what we do with neuromuscular blockers to hedge our bets is we just double our dose. And remember, this is a logarithmic scale, so it shifts to the right, which you can see here is the very steep part of our quantile dose response curve, and probably ends up capturing over 90% of the population, making our intubating dose of 0.6 milligrams per kilogram for Rocuronium. And you'll see this with many of our neuromuscular blocking drugs. Usually it's just double whatever the ED95 is in the individual to give us our intubating dose. When we talk about rapid sequence induction doses though, it's 1.2 milligrams per kilogram for Rocuronium. And we of course do increase the amount of the population that will have a 95% reduction in the first twitch height. But if you look at the response curve, we end up in this plateau, and the real reason for the dose is not for the reliability of the block, it's because at a higher dose, it creates a higher concentration gradient or for the plasma to the effect site. So you have a faster onset, hence a better for rapid sequence induction. It essentially reduces your intubating time from about 90 seconds to around 45 seconds. In fact, a point I should make here that helps us explain the shape of the graded response curves and why the Quantal dose and the graded dose doesn't start at 0 is because with neuromuscular blocking drugs, you need to achieve a minimum of 75% receptor occupancy before a block will develop. And this is due to the margin of safety with excess and redundant amounts of acetylcholine released into the neuromuscular junction for a standard stimulus, which I describe in my neuromuscular junction video, which I've just linked above. So we've talked about how rocuronium's ED95 is a 95% reduction in twitch height in the individual on the graded response curve. But when we talk about ED50 of rocuronium, what we're actually saying is that 50% of the population will have a 95% reduction in their first twitch height, and this is on our Quantal response dose curves. So that's why it can become quite confusing. And our ED95 dose is 0.3 milligrams per kilo, but we hedge our bets and we double the dose to increase the percentage of the population that will have a block of about 95% on their first twitch height. But neuromuscular blocking drugs are interesting because realistically, when you give it, you're trying to achieve that greater than 75% block. Ideally, you want greater than 90% of the receptors occupied by the drug to achieve adequate intubating conditions. But this can also be really dependent on physiological, pathological, and pharmacological states that shift our ED50s of rocuronium to the left or to the right. So some things that make rocuronium less potent, which shifts the curve to the right, meaning you need more drug, are things that either increase acetylcholine in the neuromuscular junction or increase the number of receptors or change the membrane potential of the cells. So the way I like to break this up when I talk about potency of drugs, specifically neuromuscular blocking drugs, is I talk about pharmacological factors, pathological factors, and physiological factors. And then I would divide it in half and have on the right side my right shift and on the left side my left shifts. And remember, right shift is less potent and left shift is more potent. So I'm just going to start a little bit backwards here and talk about things that right shift to make it less potent. So we'll start on the right side of the screen here. So in terms of the pharmacological factors, giving neostigmine increases acetylcholine at the neuromuscular junction as it inhibits acetylcholinesterase, decreasing the breakdown of acetylcholine. Giving reversal agents such as Gamadex, chelates rocuronium, and other neuromuscular blocking drugs such as Vecuronium, and some books mention pancuronium to a degree as well. Chronic anticonvulsants can also shift to the right. And then there's pathological factors. So the classic is a burns patient with greater than 25% body surface area, any denervation or upper motor neuron lesions and spinal cord injuries, prolonged immobility in ICU or in general, and sepsis, which all lead to upregulation of nicotinic acetylcholine receptors. And then physiological factors. Men generally need a higher dose than women because they've got an increased lean body mass with increased muscle tissue. Things like alkalosis, hypercalcemia, hyperkalemia, and hypomagnesemia due to their effects on resting membrane potentials, overall making them more excitable or increasing concentration gradients to activate acetylcholine release. And then when we talk about factors that increase potency or left shift our Quantal dose response curves, these are things that decrease acetylcholine or decrease the number of receptors in the neuromuscular junction. Pharmacological factors are things like volatile anesthetics, local anesthetics, gentamicin, magnesium, furosemide, and other neuromuscular blocking drugs, which I actually go into detail and explain in my neuromuscular junction video, which I've linked before in the video and also down in the description as well. Essentially, they antagonize the release of acetylcholine at the neuromuscular junction. Then you have pathological states like myasthenia gravis, and this is because antibodies attack the neuromuscular junction, specifically the nicotinic acetylcholine receptors, which decreases their number. And then physiological factors are things like acidosis and hypothermia, which decrease the function of acetylcholinesterase. There's hypocalcemia, hypomagnesemia, as magnesium antagonizes calcium channels, and low calcium means there's less gradient to enter the nerve to stimulate acetylcholine release. And then hypokalemia, which hyperpolarizes cells, making them harder to reach threshold. Which again, I explain these in my neuromuscular junction video linked in the description below. Lastly, a really interesting thing I came across was that rocuronium tends to have a shorter duration when given in the afternoon versus the morning. I'm unsure of the exact mechanism, and when trying to read around this, it seems that it may be due to circadian effects on liver blood flow and metabolism, but it's usually quoted that less than 5% of rocuronium is hepatically metabolized. So I'm honestly not sure what the effect is, and I'm not sure whether I'd write this in an exam unless it was really hunting for points and had maxed out on everything else. But if you guys know the answer or have a theory why, please leave it in the comments. I've linked some papers below that mention this as well in the description. So just to summarize, we've talked about graded and quantile dose response curves, graded being in the individual with continuous response, quantal being in the population with a binary response. We talked about a tricky concept of ED95 in neuromuscular blocking drugs, which is actually the ED50 on a quantal dose response curve. We talked about Rocuronium's ED95 and what we would give for intubating conditions. And we talked about potency as well with curve shifts left and right. I've also discussed opioids in detail earlier in the video, which I also just split into a separate video as that's a separate exam question that does come up sometimes. So thanks for watching, and if any of that helped, please leave a comment, like the video, subscribe, and let me know if there's anything you want me to cover in the next videos.